Welcome, everyone. Thank you for joining our BioFire webinar. I'm Nathalie Broussard with BioFire at FilmArray, and today we have the pleasure of welcoming Professor Dr. Stefan Gehring from the Gutenberg University in Mainz, in Germany, and he will be talking to us today about the applicability of the BioFire Gastrointestinal Panel as point of care in the pediatric population, the pediatrician's point of view. For your information, we'll be taking some questions at the end of the session. You have a Q&A box available for all of you attendees, and if you want to ask any question, please put them on the Q&A sessions, and we will be taking all of them at the end of the session. Dr. Gehring, thank you very much for being our speaker today, and I let you start on your presentation.
Yeah, thank you very much, and welcome everyone who is joining this webinar, and hopefully can provide you with some valuable information. The insight that I would like to provide is our experience with the gastrointestinal panel here in the Children's Hospital of the University of Mainz. And just a little bit of a background about myself. So I've started my pediatric residency here at the Pediatric Hospital in 1997. I finished my training around 2002. Then I left Germany for 3 years to the US and did some research at Brown University at the Liver Research Center. And then in 2005, I rejoined the hospital here, continued my career, became a pediatric attending of the Intensive Care Unit and the Department for Infectious Diseases and Gastroenterology. And since 2013, I'm heading this entire department. I do have quite some interest in research, and we really perform, I'm heading a lab here that is focusing on microbiome research and epidemiology of viral infections. And we have worked over the past 20 years on syndromic testing in my own laboratory. So we have evolved a little bit over the time, and thus from this experience resulted our interest in testing the BioFire panel system. Just to give you some background about our institution. So we are the only university hospital in the state of Rhineland-Palatinate, which is in the far west of Germany. We have really a large catchment area of the entire state and even surrounding states. And we are really the only institution of its kind in our state. And with regards to the intensive care unit, where we have also placed our BioFire system, this is also a large intensive care unit for at least German standards, and we do handle around 500 admissions a year. And I think every pediatrician can share my experience that our main challenge is really the broad range of diseases that we see and that we treat every day. And that includes, of course, a large variety of infectious diseases. Of course, starting from respiratory tract infections to all the way down to opportunistic infections in children that are immunocompromised. And since it's oftentimes really quite challenging to identify the causing pathogen, we really felt over the last years that it's important to implement testing systems that spread over the entire array of infectious pathogens that children encounter. So point of care testing, I think in pediatrics is really something that is not really novel because our patients demand instant, let's say, attention, and we really try to get as fast as possible to the cause of the disease that we encounter. And thus, for example, on an intensive care unit, we have a whole array of point of care testing, starting from X-ray or ultrasound. Here in our unit, we have a coagulation time measurement or blood gas analysis and blood sugar measurement. So point of care testing is really something that has evolved over the last years, and that we have now the opportunity to even include pathogen detection is something that I value a lot. As we often observe, I think, in clinic, if a system is valuable or not, that is something that is more or less decided by the way it is used. if something really provides valuable information, most physicians will tend to really use it a lot and implement it in their daily practice. And just to give you an idea of how many panels and what type of panels we have used over the last 3 years since we started the BioFire testing, and these are just the numbers that we have used on our intensive care unit. We have an additional system also in our outpatient department. So you see over the last 3 years, nearly 600 respiratory panels. Nearly in the second place, you see the meningitis panels with nearly 200 tests, and the gastrointestinal panel with nearly 80 tests. But as I can tell you, we really use it in an increasing number, and as I will outline later, you will understand why it has become a valuable tool for us. So with regards to gastrointestinal infections, I think we all agree that this is really a large number of patients that we deal with that are hospitalized with GI infections, or even that we treat in the outpatient department. And even though the number of deaths are thankfully declining to nearly 500,000 children a year, still it is one of the leading causes of death in children, and nearly every 10 out of 10 children, one child is going to die due to a diarrhea. Thankfully, I think let's say in Europe or in our field, we don't see thankfully a lot of deaths, but still the morbidity caused by infectious diseases is of quite some significance. I like this kind of picture that you see here because it gives you an idea what are really the most relevant pathogens. And just by the size of the square that you see here on this image, you will see that, of course, one of the leading infections are rotaviruses, followed by adenovirus and norovirus on the viral area. On the bacteria infections, you have as the leading cause cholera disease and Shigella, and various types of E. coli and Salmonella as pathogens. Parasitic infections are less prevalent, but still amoebiasis, as you see in the far right upper corner, is definitely a significant cause of parasitic infections along with cryptosporidia infections. So there's quite an array of pathogens that can cause diarrhea and that can really cause significant morbidity in children. So why are children really still dying from diarrhea, and what are the causes of the morbidity that we see? I think I mean, it's like a close call that, of course, hand sanitation is a very relevant aspect. Then access to supplementation of, for example, parenteral nutrition or even oral rehydration solutions is absolutely relevant in order to handle the disease. Then, of course, access to vaccines. You have, just in the image that I showed you before, you saw that rotavirus is one of the primarily cause of diarrhea in children, and there is a vaccine available, but apparently not to everyone. And then, of course, in certain cases, there's even antibiotic treatment which is relevant for treating diarrhea. Even though we know, of course, that we are very reluctant to use antibiotics in children that have diarrhea, there are certain causes, if identified, such as cholera or Shigella or cryptosporidiosis, that are helpful, where an antibiotic treatment is really helpful and relevant. But it's, of course, important to distinguish between these diseases, since we don't want to treat a child with a rota infection with an antibiotic treatment. So what is needed is definitely, in any case, that we know what is the pathogen that is responsible for the type of disease that we see. And but I think the demand for an accessible, fast, and sensitive diagnostic tool is quite obvious. And this was one of the reasons why we introduced the point-of-care system here in our intensive care unit and also in the children's hospital in general, because we felt that particularly with diarrhea, or particularly with children that have a gastrointestinal infection, there is really, time is really an important factor. As soon as you can start an according treatment, as soon as you can start fluid supplementation, the recovery of the child will be significantly faster and better. So just to give you an idea how that looks like on our ward, we have a little lab just next to the intensive care unit where we have all these various systems that I discussed a little bit at the beginning. On the very left, you see a point-of-care system for coagulation time measurement. In the middle, you see a blood gas analyzer, and at the very right end, you see that there is our BioFire system that we have placed on our ward. And underneath, and this just as a little side note, we have even placed a freezer because we feel that just in case we have any kind of questionable finding that we are not sure, or even a negative finding, in order to have the ability to confirm or to repeat the testing, we store every sample that we test in this freezer at least for 2 weeks, so that we have a chance for retesting or confirming the results that we got from the syndromic testing via the BioFire system. Just as a reminder, you see here the entire array on the left-hand side of pathogens that are detected by the GI panel, starting from various bacterial pathogens, Campylobacter, Clostridia, Vibrio, and E. coli, various strains of E. coli. So all the bacterial pathogens are at the top part, and then followed by parasitic infections, and at the end, the standard, let's say, array of viral infections that can cause diarrhea or gastrointestinal infection in children, ranging from the adenovirus to norovirus to saprovirus. And on the right side of this table, I am just showing you the numbers of findings that we had over the last 2 years or 2.5 years that we have used the GI panel. And what you see, and that is actually quite different from the respiratory or the meningitis panel, we see a very diverse pathogen spectrum. Just to give you an idea, if we, for example, compare that with the syndromic testing for respiratory pathogens, here we have like the top 3, like the rhinovirus infections are nearly 1/3, followed by RSV and influenza. Whereas here you see that there is no leading pathogen that is causing diarrhea, but there's a whole array of pathogens that we detect with this syndromic testing. And that, from my perspective, even underlines a little bit why it's so helpful to have a rather broad view on the patient and on the causing pathogen. Oftentimes in clinics, we really tried, at least at the past years, we tried a more focused testing, but that causes repetitive testing, since if you fail with one test, you have to follow with the next and so forth. And that is, of course, a significant cause of delay in finding and identifying the causative pathogen. So the second thing that I think is quite striking is the really high number of positive findings, where we are close to 50%. And that is also, I think, due to the fact that we really, it's based on the clinical decision if we are going to test. So only in cases where the attending on the ward or the chief resident on the ward says, okay, here we have a patient where I think testing is important, then we go ahead and test this patient. And I think that contributes to the fact that we have quite a high number of positive findings. And I would just like to give you a couple of examples how the results that we get through this kind of testing affect the way we see and treat the patient. And I would like to start here with the first case. And this is a case of a 16-year-old girl that returned from a 2-week vacation in Tanzania. And at home, she developed abdominal pain for 2 days. She developed diarrhea without blood and quite a high fever, with the max of nearly 40 degrees Celsius. And this girl was admitted to our hospital to rule out malaria infection. And as you know, we in Germany and in many other places, we travel quite a bit. So this is not like a rare case. This kind of presentation of children that coming back from their vacation and presenting with some type of abdominal discomfort and diarrhea is really something that we see on a common base. And we performed the standard lab testing, and also since it was suspected, we tried to rule out any type of tropical infection, malaria, chikungunya, and dengue tested, came all back negative, but still this girl had quite a high CRP value indicating some type of bacterial infection. And we also performed conventional microbiology, and here we got a Campylobacter in E. coli positive culture, but the result came 5 days after the girl was submitted to our hospital, and parallel to that, we performed the testing with the BioFire system. And what you can see here easily is that we got pretty much the similar response, a little bit broader array of enteral of E. coli. But I think based on the, let's say, on the clinical presentation and on the lab findings and on the presentation of the child, we decided that very likely the Campylobacter infection here was the most significant finding, which was primarily found by the BioFire system and secondly confirmed with the microbiology. And in this case, we decided not to treat with antibiotics. Generally, we avoid antibiotics in GI infections, except of the cases that I mentioned at the beginning. And according to our guidelines, in Campylobacter infection, we usually, if the patient is in a stable condition, don't treat. And thus here, the testing really supported this kind of decision from an early stage on. The next case that I would like to show you is here a 15-month-old girl. And in this case, we had the girl had a congenital heart issue and was required a catheter intervention. And while being in the hospital, she presented with vomiting and diarrhea and high fever. And along with that, we found a significantly elevated CRP value, again indicating the salmonella bacterial infection. And in the microbiology, and I even provide you here with the resistance pattern of this salmonella, we got the result that the girl had a salmonella infection. And since the girl was in the hospital, we decided to start, due to the underlying condition of the heart issue, to initiate an antibiotic treatment. And while being in the hospital, the girl first improved, and then suddenly the symptoms reappeared with significantly elevated temperature and with the reappearance of the symptoms. And based on the reappearance of the symptoms and the deterioration of the clinical condition of the child, we decided to perform BioFire. And the BioFire, for one, confirmed the salmonella infection, which we already knew and which was treated with cephalosporin. But in addition, we find in the BioFire testing that the girl acquired norovirus. And that is, of course, something that unfortunately happens in hospitals, unfortunately even quite frequently. What happened here is very likely a hospital-acquired infection. The child acquired while being in this particular ward the norovirus, which is an important information for one, because we had to isolate the child. And for two, norovirus is very contagious, and we have specific hygiene measures that we implement as soon as we detect norovirus. Of course, salmonella is also infectious, but at least according to my experience, norovirus is significantly more infectious, and that's why we handle that differently. So this is a very important finding, which helps us to contain and to monitor hospital-acquired infections in this particular case. So the next thing, the next case that I would like to present you again is a 5-year-old boy. And I mentioned at the beginning, we do see a lot of patients that come back from vacation, and that was also here the case. So this boy was suffering for 2 days with constant vomiting and diarrhea and elevated temperature. Again, CRP values indicating bacterial infection. The microbiology confirmed that with salmonella and adenovirus, which we received 2 days after admission. And the information that we received here through BioFire, which was confirmed just 1 day after admission, confirmed on the same day what we later found in the microbiology, a salmonella and adenovirus infection. So here, in contrast, for example, to the child before, we decided not to treat with an antibiotic treatment. And this shows you how relevant it is to get this kind of information. Because on the one hand, if you have salmonella in a child with a congenital heart defect, we will treat with antibiotics. But normally, as shown here in this case, if a child has a salmonella infection, we usually avoid antibiotic treatment, since there is some indication that if you perform antibiotic treatment, the colonization with salmonella can be somewhat extended. And the other thing that we see is the quite good overlap between the BioFire testing and the microbiology that we performed. Then another case that I think is quite interesting is a girl that presented, a 2-day-old girl that presented with diarrhea and fever. And the specific thing that struck us here in this case was not that this girl didn't only have diarrhea, but on top, bloody diarrhea. And that's something that we don't see so often here, at least in Germany. In other countries, that's of course much more common, but children presenting with blood-stained diarrhea is something that we see not on a regular basis. The other thing that was somewhat concerning was that the urine color had turned brownish, and that the urine output of the child just shortly after admission and shortly after hospitalization really was extremely low, to a point that the child became anuric, so had no urine output, no urine output. And we started with diuretics, and the child unfortunately did not respond to the diuretic treatment, so as we expected. We performed, of course, conventional microbiology, and all the viruses came back negative. That's something that we usually get on quite fast, in contrast to the, let's say, bacterial pathogens. And we had some suspicion that we might see here a case of hemolytic uremic syndrome. And the suspicion was based not only on the clinical findings that I outlined, but also on the lab values. In particular, the elevated creatinine level, and the elevated uric acid and the urea indicated that there is some kind of combination between, let's say, or connection between the clinical presentation and the kidney failure that we saw. And of course, based on that, the suspicion of hemolytic uremic syndrome was quite high. And we performed then the BioFire testing just on the day of admission, and the BioFire testing came back quite fast and confirmed our suspicion that the child had a Shiga toxin like producing E. coli. So we could confirm at the day of admission that the child was suffering from a hemolytic uremic syndrome, which then triggered the let's say referral of the child to a center where kidney replacement treatment was available. And this is what was for us really novel, because usually it takes quite some time to get a confirmation of the suspicion of hemolytic uremic syndrome. And what you can see here in our, let's say, conventional microbiology, you see the enormous time delay. So the sample, the stool sample was received at the 12th of June, and the result came back. The final result came back 10 days later, and that shows you the huge advantage that we had through the availability of testing that provides us already at the day of admission with the result of and with the result that confirmed our suspicion. And along with this child, I would like to give you an insight of the whole case series of hemolytic uremic syndrome. Here in Germany, this kind of clinical presentation or the hemolytic uremic syndrome is something that we don't see on a common base. I would think that during a whole year at our hospital, even though we are a tertiary center and a referral center, we see 1 to 2 cases. But we are collaborated with the institution in Argentina where the incidence of this disease is significantly higher, so we could combine our patients and had here a whole case series of a total of 15 patients that are in the median nearly 2 years old. And all these children were referred to the hospital and hospitalized due to the suspicion of a hemolytic uremic syndrome. And as not so surprising, most of these kids need intensive care unit support. So 80% were treated at an intensive care unit, and all of these children required renal replacement therapy. And along with the single case that I just showed you, we could confirm the huge advantage of having access to this kind of syndromic testing, which is mainly documented through the extremely short time from submission of the patient, from let's say getting the sample to receiving the final result, which was in the case of the GI panel the median of 1.5 hours, whereas with the conventional stool culture, it took us nearly 4 days until we had the final results in the median. And all patients could be classified as typical hemolytic uremic syndrome. Atypical hemolytic uremic syndrome is something that we don't see in children that commonly, but typical HUS is something that is usually found in these cases. And there were, except of one case, all confirmed by conventional microbiology. So there's a really excellent overlap here between conventional microbiology and these molecular-based testing. The next case I would like to show you is another child with bloody diarrhea. That, as I said, not so common, but here and there we see that. So this child is a 5-year-old boy with a history of bloody diarrhea for 2 days. He was submitted to our hospital or hospitalized due to this, let's say, clinical finding. The general clinical condition was significantly better than, for example, with the children that we see with hemolytic uremic syndrome. Still, if a boy or if a child has these kind of symptoms, we always suspect HUS, but let's say lab values didn't indicate that this was the case. With a low creatinine or normal creatinine, it seems unlikely that HUS was the case. And the microbiology testing found no pathogen, but in the, let's say, BioFire testing, we were able to detect the sapovirus infection. And sapovirus is something that we don't see so commonly. I mean, very commonly, of course, rotavirus and norovirus. And sapovirus is, due to the, let's say, low incidence, not regularly tested also in our own microbiology department. So if we would not have access, let's say, to this kind of syndromic testing, I'm quite sure that we would not have detected sapovirus. And I believe that in this very case, sapovirus was the cause and was maybe aggravated through an enteroaggregative E. coli superinfection. And having, let's say, this kind of fast testing allowed us to really detect quite early on what the child was suffering from and helped us to rule out hemolytic uremic syndrome in contrast to the other cases that I presented earlier. Then there's something that I would also like to share with you, something that we find quite interesting. That is the fact that we see infections that are oftentimes associated with a neurologic impairment. So here, this is a girl that was actually hospitalized this year in our intensive care unit. She presented with, first of all, with just, let's say, a neurologic impairment. She had no vomiting, at least in the history, no diarrhea, no fever, but she progressively lost the conscience. She could not talk. She even developed seizures. And then, of course, we performed CSF tapping and analyzed the CSF fluid. We saw an elevated number of leukocytes and protein indicating some kind of inflammation here. And what we always do, and I don't want to necessarily recommend that, but if we have children that are presenting in a really bad, let's say, overall situation, we more or less test every fluid and every secretion that is available for us. So usually if we have something unknown going on, and particularly children that are so heavily neurologically impaired, we test, of course, the CSF fluid, but we also perform, and as I said, this is just the way we approach it, we also perform the rescue panel and the GI panel. And much to our surprise, in contrast to the clinical presentation of the child, we were able to detect norovirus. And along with that, we performed the MRI scan. As you can see here in the corpus callosum, there was this signal intensity, significantly elevated signal intensity. So there was apparently some kind of GI infection going along with neurologic impairment. And that is something that is actually, for one, well described in the literature, and for two, we observed that infections that are not necessarily associated with the, let's say, central nervous system, for example, infections in the respiratory tract or gastrointestinal infections, can also cause or be associated with neurologic impairment. And we found a disease that is called mild encephalitis with reversible lesions of the splenum of the corpus callosum, which is exactly where we found the lesion. And this kind of really rare disease has been described, for example, for rotavirus infection. And we believe that there's likely an association between the norovirus and this particular neurologic impairment. The child recovered well. Unfortunately, had some kind of, let's say, shrinking of the cerebellum, but overall, the child is doing quite well and neurologically in a good condition. And for us, this is just one of many cases that I can share with you of children with, as I mentioned, neurologic impairment due to infections at other areas. For example, we had a case of influenza with a severe encephalitis, enterovirus associated with flaccid myelitis, and Campylobacter infections associated with Guillain-Barré syndrome and so forth. So in cases with, such as the one that I presented with children that have severe neurologic impairment, we usually test pretty much everything that is available for us with regards to infections, or at least to rule out infections that might be associated. Next is a boy, a 3-year-old boy that I would like to show you. He was at home first for quite an extended time with high fever, max 40 degrees, and had loose stool. When the boy was admitted to our hospital, he was really in a sick condition on presentation, had significantly 250 milligram per liter elevated CRP values and high leukocyte count. And due to the really, let's say, significantly impaired condition, we treated this child with cefuroxime. And the other thing that is unfortunately not written here is that the boy had abdominal pain in his right lower quadrant of the abdomen. So there was, so we performed, of course, the microbiologic evaluation, and so for one, of course, the BioFire GI panel, and here we detected Yersinia enterocolitica, which was confirmed by conventional microbiology. And based on this finding, we briefly stopped, or we soon stopped the antibiotic treatment. And I think what I would like you to stress is that the type of presentation can be easily mixed with appendicitis. So high fever, abdominal pain, somewhat loose stools, and high CRP values is something that we also would see in a child with appendicitis. And having, let's say, an early kind of detection, I think is extremely valuable if you want to avoid, for example, unnecessary surgery. So to have the ability from early on to kind of classify what is the causative, what is the cause of the clinical presentation is, I think, very valuable, because it distinguishes the Yersinia infection, which is known to resemble appendicitis, from the true appendicitis, and thus you avoid unnecessary, let's say, antibiotic treatment, and of course, in some cases, even unnecessary surgical interventions. And the next child that I would like to present is also something where I would show you that maybe findings have to be seen somewhat cautiously. So this is a 3-month-old boy with congenital heart disease. It's a Shohn complex, congenital heart malformation, a coarctation of the aorta, which is a stenosis of the aorta. So the boy was admitted with failure to thrive, but had no diarrhea. But after getting heart catheterization and intervention, he developed diarrhea. And what we, again, of course, performed was BioFire testing and also conventional microbiology, and we could detect Clostridium difficile toxin in this case. But we were, and I am still quite sure that the diarrhea very likely had nothing to do with the positive finding of C. diff in this case. Just based on my own experience over the past 10 years, I can only recall one single really significant C. diff infection. And as you might know, we really regularly find Clostridium difficile toxin or even Clostridium difficile pathogens in children. This is something that is seen in many children. And in most cases, I think, and this is also supported by the literature, these findings are basically colonizers. So, of course, it's very valuable to have this kind of panel, but I also would like to stress that some of these findings might be not clinically significant, as in this case. So there is, for example, a quite high prevalence of certain types of E. coli that are considered to be pathogenic, but still I and others see them rather as colonizers. And secondly, diff is another really good example of colonizing bacteria that have, for example, in this case, no clinical significance. Just as a reminder, the carrier rate of C. diff in newborns is 80%. And usually, and that's why you have to be somewhat aware of, we don't even test newborns for C. diff. But since the panel includes this pathogen, of course, if you perform this type of testing, you will get a positive finding in many cases in newborns and in young children. But again, I would like to remind everyone to be somewhat cautious with these findings and to be just aware of the general prevalence and the general numbers of colonization. Finally, I would like to give you a case that shows you how the syndromic testing might be relevant in order to control outbreak situations. So this year, and again, it was during summertime, we had a 3-month-old girl with congenital heart disease on our cardiology department that underwent a complex heart surgery. And 4 weeks into hospitalization, this girl started to recurrently vomit. We performed at the same day the syndromic testing, and we detected norovirus. And unfortunately, during that time, pretty much the same day, and those people who are, let's say, have some experience with norovirus, they know that norovirus is really spreading extremely fast. 3 healthcare workers at the same ward developed as well GI symptoms. And over the next whole week, a total of 20 healthcare workers in our hospital of around 140 nurses became sick, so really quite a large number. We had to shut down one ward, and we performed during that time a lot of testing. Here the thing is, we are not allowed, at least in Germany, I don't know how it's in your place, to really test healthcare workers. But due to the finding with the child, we were quite sure it was norovirus, and of course we implemented hygiene measures. We isolated the child, and we were able, thankfully, to contain the infection to only 1 patient. And through closing down the entire ward, we were then able to also to stop spreading within the healthcare provider community. But the availability of testing in our hospital was at this point quite helpful, because then, of course, we had other children with diarrhea, but these children were confirmed as norovirus negative, and thus it was really a very helpful tool to survey and to control this kind of outbreak situation, and really to more or less contain the infection and avoid total spread through the entire hospital. So no other patient was found positive, fortunately, despite 3 other children with GI symptoms that were tested. And as a take-home message in this particular setting, I would just like to stress that the point-of-care testing allowed us to really contain the further dissemination of infection through our entire hospital. So I think the various cases that I show you really give you an idea how we use this GI panel. And what I would like really to stress is that we see really a very diverse type of findings. This GI panel shows results all over the place. And it is really helpful in therapeutic decision making. And I just gave you the example of, for example, the Yersinia infection. I showed you how we differently address salmonella infections, how we are able to identify very early on the severe disease of hemolytic uremic syndrome, which helps us then to, let's say, refer the children to an according treatment, and that we have a tool in our hands that helps us to control and to survey hospital-acquired infections. And I also would like to point out, and I did that I think already, but just as a reminder, be of course cautious with what you see, and view the results in the light of, let's say, what we know about colonization rates and what we know about the, let's say, significance of certain pathogens. And as here I show at 0.5 is that C. diff and EPEC is something that is that are colonizers in children, and thus the results should be viewed with some caution. In general, my experience, and that's why I show this picture, is that children's hospitals are from me and from my experience, really like the perfect storm for syndromic testing, because we face and we handle all kinds of infections. This is the one thing, and on the other hand, side, we really are we are dependent on timely results in order to make our decisions. And thus, in general, my experience with point of care, let's say, testing, and that is not only, let's say, applicable to the GI panel, but also to the other panels that we regularly use. We have this, they have really results in a short period of time. And through the fact that we have the whole system on our ward, we avoid even the whole issue of transporting the samples to a certain place and waiting until the results are sent back to us. We have a tool in our hands that makes therapeutic decision-making really possible on time. And another big advantage that I outlined already is that we have access to infection control. Patients, according to my experience, can be treated more adequately and targeted, and unnecessary treatment can be avoided. And that's something that I value a lot. So just to give you, I hope I gave you a little bit of an overview of our experience, and I thank you for your attention. And point of care testing can be sometimes very easy. And this is just my kids that had a case of head lice. And I think pediatricians, and I hope you agree with us, we are really those who are very close to the patient. And this closeness, this is, I think, promoted through these kind of testing that I described. And the closeness is, of course, relevant to find things such as head lice. So thanks very much for your attention.
Thank you, Professor Gehring, for your very insightful presentation. We love the picture of your kid with a head lice. Nice picture as well. Now it's time for questions. Please, if you have any questions, just put your question in the Q&A panel on the right-hand side. We have a few questions already for you, Dr. Gehring. So, as you have the results faster, could you see a decrease in the diminution of the length of stay at the hospital?
Yes, we do see that. Just one example is, for example, the hemolytic uremic syndrome. Here, due to the really expedited, let's say, detection, we are able to address this disease earlier on. And the other example that I think is, for example, very relevant for us is these salmonella infections. As I said, or salmonella or Campylobacter infections, if we see these, Campylobacter is also a good example. If we see these infections, and if we know that this is salmonella or Campylobacter, as I mentioned, in most cases, we avoid antibiotic treatment. And if we avoid or even cease antibiotic treatment, that has a direct effect on the days of hospitalization, because since these children have diarrhea or vomit, they're not able to take orally antibiotics, so they have to get parenteral infusions. And if this is not required any longer, we send these children back home. And thus, this has a certain effect on hospital duration and hospital stay.
Right. Thank you. The other question is, do you know approximately what was the positivity rate that you got from the lab before you implemented the GI panel at your point of care setting?
So the positivity rate, I think the rate of positive findings, it's a little bit difficult to compare, because the difference here is in the times, let's say, before we had the GI panel, we have more or less 3 different departments that we have to send the samples to. If we suspect viral infection, I don't know how it's in most hospitals, I think it's similar, but so if we suspect viral infection, we send to virology. If we suspect parasitic infection, we have a parasitology department. If we have bacterial infection or suspected bacterial infection, we send it to our clinical microbiology. And of course, the positivity rate is different based on the, let's say, suspected pathogen. In the GI panel, I showed that we had a positivity rate of around 45%. In the, let's say, various types of conventional microbiology, it ranges between 20 to also nearly 50%. So when we have suspected viral infections, the overlap between the GI panel is quite good. In the other cases, the overlap is not that great. And I would think that the positivity rate that we see with the GI panel is higher than what we see with the conventional microbiology.
All right, thank you. As you have like a positivity rate pretty high, do you often share the results of your finding with the parents?
The last one I didn't understand, sorry.
Do you share the pathogens that is detected with the parents of the kids?
Absolutely, we do share them, and we also feel that this is helpful. If the parents know what we find, it's much better and easier, according at least to my experience, to convince them to adhere to, for example, hygiene measures. As you know, hygiene is a big issue in our hospital, and if we can tell you, for example, parents, your child has norovirus, and thus you have to put on a mask, you have to put on gloves, you have to be really cautious and absolutely adherent to hand sanitation. It's, I think, much better to convince them. And also for similar things, for example, for salmonella infection, for example, we try to teach our parents, if the child has salmonella infection, ideally, if we discharge the child home, it has to use its own bathroom, and the bathroom has to be clean so that we don't see it spread through the entire family. So knowing the pathogen is something that is very important, and that we always communicate to the parents in order also to educate them and to give them the idea what the child is suffering from.
All right. There's another question for you as well. Which metric was used for testing in neurological impaired patients?
So, I understood right, which pathogens we see usually in cases of neurologic impairment, is that right?
Yes, the metric that was used for this patient.
Which sorry?
Was it tool, was it CSF, like which metrics exactly was used?
Okay, that's a very good question. So just to give you an example, we had recently a child with what we call flaccid myelitis. This is a form of infection of the bone marrow that unfortunately leads to a complete paraplegia. So the child was not able to move both legs. And it was a young boy, 10 years old. He was a soccer player, and he could not, and he was admitted due to the inability to move both of his legs. And the disease, or the pathogen that is causing this disease, is actually quite well described. It's a polio-like virus. It's an enterovirus. And these viruses are usually found only, in most cases, only in the stool. And these outbreaks are well described and also published. And we have published also our case. And so of course, here the leading symptom is a neurologic symptom. And of course, we perform spinal tap and we test the CSF fluid. But in most cases, CSF fluid comes back negative. And that's why I indicated that you definitely have to test in these cases stool and also respiratory samples, because enteroviruses are usually hiding there, or the infection or the colonization is going on there. So if you have this kind of neurologic impairment, we always, in most cases, we test stool, CSF fluid, and respiratory tract fluid. Because, as I said, the CSF fluid is mostly negative, but the pathogens are hiding or sitting or colonizing the respiratory tract and the gastrointestinal tract. So this is really a very important point.
All right, there is a precision about the question that was just asked before, and thank you for your answer first. There was a norovirus diagnosis that was described on your slides before. And in this case, which sample type was used? I guess it was a stool as well, but can you confirm that, please, in your norovirus case?
So this was the child with a norovirus infection and the the affection of the neurologic impairment. Is that the question?
Yes, exactly. What was tested on to get like the norovirus result?
The stool sample was tested. So as I said, we test all three kind of accessible, let's say, sample stool, stool, respiratory tract, of course, and CSF. But of course, norovirus is only detected in the GI panel, and we tested it in the stool sample.
All right. Okay. Thank you. Any more questions? I think we are good. I cannot see any more questions. So thank you very much,
Okay.
Gehring, for your presentation. And we wish you a very good day. And thank you, everyone, for attending. We will send to all of you the on-demand webinar so that you can go and listen to it one more time if you want. That will be available for you very soon. Thank you, Dr. Gehring.
You're welcome. Bye-bye.
Bye.